From Ausmed Education, hello and welcome to episode 8 of the Care to Learn podcast series. I'm Wayne Woff, and each month I sit down with interesting and influential professionals working within healthcare and education. In this episode, we're extremely excited to be sitting down with Steve Pitman, a nurse practitioner candidate with the East Hume Region Palliative Care Service. Steve is an incredibly experienced nurse, and he speaks beautifully about why we must work to provide individualised and contextualised care, particularly in the palliative care setting. In today's episode, we'll discuss how mentorship can be used to enhance the translation of new knowledge into practice, the importance of soft skills within palliative care, the critical role of education and support of clients and families, and finally, why it's essential to better incorporate care workers into care planning discussions for clients. So let's get into it. Well, welcome everybody to this episode of the Care to Learn podcast. Great to have Stephen Pitman with us here today. Welcome to you, Steve.
Thank you very much.
We'll kick off today, as we traditionally do with our Care to Learn podcast, by letting you tell the audience a little bit about yourself, your personal, professional background, your journey, just to kick us off today.
Sure. So, I came into nursing quite late. In my late 20s, I was a typical 20-plus-year-old bloke, sort of going from job to job and not knowing what to do career-wise, and I actually went into palliative care volunteer training and enjoyed that experience so much I thought, this could be interesting. So I went into nursing with a palliative care bent right from the very start. So, I've always had a sort of a passion for palliative care. So I did my nursing and then a graduate year, and then went straight into working for a community specialist palliative care team. And then transitioned into, clinical nurse specialty and then clinical nurse consultant. And so a very sort of strong component of that was, education, definitely in terms of supporting primary health care providers who provide palliative care. So,
Well, we've got that similarity in that I started my nursing career a little bit earlier than yours, but I very quickly, along the journey of my nursing career, established that I wanted to work in aged care. So it was very much for me, possibly similar to you, that you found a clinical area, a particular work area that you were passionate about and wanted to do. So you touched on education there, Steve. Your passion for education and interest in education has been a thread throughout your career since commencement?
Yeah, absolutely. And I think it's the nature of how palliative care is set up too, in the sense that the majority of palliative care is actually done by the primary healthcare providers. So as specialist providers, sometimes we're a little bit of a blow-in. We come in and put our 2 bobs worth in terms of complex symptom issues or complex cases and, even complex ethical issues. So we're quite often working with the primary healthcare providers in that space. So that almost lends itself to mentoring and education and so forth. So it seems to be almost a natural extension of that specialty role, I think.
Yeah. And in teaching about palliative care, what would you consider are your key pillars or foundation principles that you work off, in a sense?
I think in terms of education, the thing that I'm becoming increasingly passionate about is the mentorship. There's only so much you can actually do in terms of presentation of clinical expertise. It's about the application of those clinical skills. I think that's where the rubber really hits the road. In the nature of my education, I'm talking about terminal conditions all the time, and one terminal condition we don't often talk about is death by PowerPoint. And so trying to avoid that and actually getting people into a reflective and a contemplative space where they can actually really start to think about the application of that knowledge in their day-to-day work. I think that for me is where I try and put the emphasis on my education, I think.
Yeah, so it's something that we've discussed before in these podcasts. It's not just about knowledge, it's not just about information. It's about the ability to translate, it's about the ability to apply. And also the other thing I wanted to touch on was the I suppose, the balance between what we might call the soft skills of communication, negotiation, mediation to a degree in that palliative care space and the clinical skills. Do you think that it's important that both of those are addressed with providers, with individual staff, that they recognise that suite of skills is needed?
Absolutely, yeah. We did a research project in New South Wales actually around an online learning package for palliative care. And so we actually did pre and post-test knowledge and confidence testing, and then followed them up 6 months later. And what we found was that there was definitely a measurable increase in confidence and knowledge pre and post-test. But 6 months down the track, they still retained the knowledge, but we couldn't say the same thing about confidence. So it's that thing of, we can have the content, but what we need is the application as well too. At the workshop today, so one of your facilitators, I'm going to quote her.
Right.
She was quoting Oscar Wilde, and she said, "The job of education is not to fill the pail; it's to light the fire underneath it." Yeah, and I think it's really about developing that capacity to enable people to apply the knowledge and the application of knowledge. I think. Yeah.
And just digging a little bit further into that space of what are often referred to as the soft skills. The one I want to pick up today in our discussion is that skill of listening. How important would you consider that to be in the space of palliative care?
Yeah, absolutely. It's probably one of the most necessary skills is actually to sit down and shut up. And I think it's that quote of, we've got 2 ears and 1 mouth for a very good reason.
Yes, get the balance right.
Yeah, exactly. And, I think it's recognising that in healthcare there is definitely a power imbalance there between clinician and patient and family. And so the ability for patients and families to actually set their own agenda is so important. We're going into homes and, of course, asking about their pain, their bowels and all this sort of stuff, and it might not be the most pertinent thing that they're actually concerned about. So, yeah, the fine art of sitting down and shutting up.
And also just that ability to constantly remind yourself to the individual circumstance that presents with each and every person, isn't it?
Absolutely, yeah. So every situation is contextual, and I think it is consideration of each individual person and also their family caregivers too.
I think here on our podcast we might change the word individualised with context, and context which clearly takes in the individual person, the client, the patient, whatever tag we're going to put on, but what surrounds that person, where they live, whether they're isolated, whether they're in a rural setting, a metropolitan setting, the amount of family and active family members sometimes, and all of those things build up that context, don't they?
Absolutely. I think a great example was we had a physician by the name of Eric Cassell who's written a book called The Nature of Suffering. I saw him speak at a palliative care conference. He gave an example of a 74-year-old presenting to emergency department with pneumonia. His question was what caused the patient's pneumonia. Of course, the standard accident and emergency answer is bacteria. What do we do? Sputum cultures, chest x-rays, put them on antibiotics, retrieve them, send them home. And he takes it to a next step and he says, what if I told you he had rheumatoid arthritis in his knees and he lives in a 2-story flat? What caused his pneumonia? So, is it access to nutrition? Is he sitting in a recliner chair with a simple cold? Not able to mobilise and it develops into a pneumonia. Is he socialising? Is he going down the local bowls club like he used to? And then he takes it one step further and he says, what if I told you that his wife died a year ago? What caused his pneumonia? Yeah. So, is it loss and grief? Is it depression? Is it social isolation? So that thing of, we treat disease very well. We don't necessarily treat people really well, I don't think. So, I think, contextual and individualised, I think, very important in palliative care.
And it's hugely important, as you rightly say, you concluded your remarks there in palliative care, because you are, without overselling it, talking about a person's life as opposed to a young, fit individual, 25, with a fractured leg. The context around that and the complexity potentially is a lot less. And we need to appreciate it, that every day that we're involved in palliative care, the multi-layered nature of the work we do.
Absolutely. Yep.
So just picking up on that, in terms of Information, education, and then translation to practice. You touched on it briefly, and we might just take it a bit further about what do you see as some of the barriers to that translation and rich translation to practice of information that clearly is out there in a lot of different forms, face-to-face education, online learning, readings, articles are in an information-rich part of human history. So yep. What are the barriers that you see?
Well, going back to that Oscar Wilde quote, I think it's, we're very good at filling the pail. But yeah, lighting the fire underneath is a completely different ballgame. And I think where the gap lies is probably in that considered mentorship, I think, too. Yeah. With, evidence-based medicine, the early proponents of evidence-based medicine said that it was so much more richer than just the research evidence. Of course, the research evidence is our, major pillar in terms of evidence base, but they also postulated that it was the individual patient's circumstances, as you rightly said. So it's about context. But they also said it was the clinician's wisdom too. So, they talk about it in medicine in terms of, clinical decision-making and so forth. In nursing, we talk about it as nursing intuition. Interestingly, the ancient Greeks used to have a very similar division of knowledge too. So they used to talk about episteme, which was the root word for epistemology. So that was the research component, yeah. And they talked about techne, which was the knowledge that enabled the craftsmen to craft their pots and so forth. Then they had this word called phronesis, which actually literally translates as practical wisdom. And so practical wisdom really aligns itself well with that nursing intuition. Mm. And so what did the ancient Greeks say about that? Well, they said the components of phronesis are hindsight, so reflective practice, so being able to look back on our clinical experiences and allowing that to inform us into our future. They talked about foresight, so anticipatory care planning, for palliative care patients, making sure that they've got their alternative subcutaneous medications there ready to go when they're approaching the end of life, instead of 3 o'clock on a Saturday night when there's no access to a GP. Compassionate care, so actually really investing yourself in a person suffering and in their circumstances. That's part of our wisdom that we bring to the table as well. Eloquence was another thing they talked about too. So us being able to articulate our clinical case, when we're advocating with a GP for, adequate pharmacology for somebody who's approaching the end of life, let's do it in a way that is eloquent so that, we can actually really develop our clinical case. And prudence was the other component of practical wisdom too. So that thing of getting away from the binary yes or no's, the easy answers, the black and whites. We're working with people here, so the palette's much more rich than just the black and whites. So prudence is about being able to navigate the unknown, I think.
And I think that's for our listeners a terrific summation. And in terms of the shades, the colour palette, as you referred it to, you couldn't find clinical specialty in my mind that doesn't need it more than palliative care. And I think you've painted a terrific picture there. In terms of, I'll pick up on one thing that you've touched on lightly, but just maybe take the discussion a bit further. What might be termed as professional missteps or mistake from an educational point of view, and putting your palliative care hat on. How important is it to look at those things, analyse those things? You touched on it in terms of your word hindsight there. What we can learn from previous situations, previous clients. From an educational point of view, do you take the view that it's incredibly important that we do that? We're willing to be honest and say, we didn't do this well, we have to do it better next time, we need to learn.
Absolutely. So I think I touched on death by PowerPoint as a terminal condition. Well, the other terminal condition I haven't spoken about is expertosis. And so I think there's that sense of if I get to a situation where I believe I have learned everything there is to know about palliative care, it's time to resign, I think.
Or shoot me.
And so I think it's that thing of actually when you're in a workshop or, in a seminar situation is actually appreciating that actually everyone brings their own wisdom to the table. So enabling people within that workshop space to actually be able to be self-reflective as well too. and to be able to bring some of those experiences to the table are really important. And yeah, I'm open and honest about some of the mistakes I've made too. So what I tend to do is try and, sort of fragment my presentations a little bit between the theoretical, the reflective, breaking things up with, case studies and case scenarios. And then opportunities for people just to be able to drop the theoretical and, be able to reflect in groups and so forth too. So, yeah, I think it is about being open and honest about our clinical experiences. The lady who mentored me in palliative care, I think for the first week I started there, her first thing she said to me was, "It's okay, Stephen, we bury our mistakes in palliative care." But
Indeed. And probably the final discussion point that I had down today was about education of clients and families and support for them. So conversation around that, and probably two parts of that conversation. One, just to get your take on the need for that, which I think I know your answer. But the second part of that conversation is just look at what we're doing in the educational space of professionals and their ability to educate and support families. So the first one, the need for that education and support of the client, of family members, of cousins, whoever it be. If you could just speak about that for a moment in the palliative care context.
Absolutely. I think, who does palliative care? Us as nurses and as, medical officers and so forth, we're actually going into people's lives for a very brief moment in time. In the community setting, we're only going into the house for maybe, 1 hour a day at the most. Who's actually doing the palliative care at the end of the day? It's actually the family caregivers who are providing the palliative care. So the education and of family is absolutely essential, I think. And again, that thing of appreciating context, so being able to sit down with family and be able to appreciate where they're coming from and where their complexity lies too.
Yeah. And you raise a great point in a community setting, as in somebody's home.
Yep.
They are doing a hell of a lot of that hands-on palliative care work. My background and experience was mainly in residential care, where you can get the reverse scenario where families at times feel very hesitant about getting involved in some of the practical aspects. And I was always of a mind to try and encourage and facilitate that, so they didn't feel that they were completely detached from the process. And again, context is king. You need to craft that according to family situations. But it's quite a difference, isn't it, between the two settings, whether it be in-home care situation or in a residential care situation.
Yeah, I'd agree. And also inpatient hospital too. So
Indeed.
Probably the example I'd like to give there is there was a 104-year-old who was in an intensive care unit in renal failure. So she's dying. And the daughters were jumping up and down and saying, "Do anything you can. Can't you dialyse her?" And interestingly, the treating physician actually asked the daughters, he said, "When was your last experience of somebody dying in your family?" And they said 1956 when her father died. So that thing of as health professionals, sometimes we have a lack of appreciation that, it's the first time that for many people where they've actually seen somebody die. Yeah. So actually being able to be brave and actually talk people through the dying process.
Yes.
What does your dying look like? Yeah. I think that's really essential part of the family and caregiver education too. Even the patient. So sometimes I'll actually sit down with the patient and I'll say, "Do you want to know what the last few weeks of your life are going to look like?" And sometimes you can, if they want to go down there, the most important thing I've done there is actually ask permission. And so if they give me permission and I lay the cards down on the table about what their dying process might look like, you can quite often just see the relief,
Yes.
It takes away some of that uncertainty and that fear of what dying looks like.
Yeah. I think it's a fabulous point you make about asking family members when's the last time you experienced within, close friends or the family, a death.
Yeah.
And the answer that you gave in that anecdote would have absolutely floored me, and I'll certainly add it to my list for future reference if I'm ever in those in that situation. Again, to the second part of the question, or the area looking, educating and supporting families, your take on the need to educate professionals about that space and how you would approach it, or how you do approach it.
I've heard some people say, it's not necessarily my role to have those difficult conversations. But, you raise the example of the PCA and residential aged care, for instance, when they're showering a resident with COPD who's got refractory dyspnea, and they say, I'd rather be dead now than to have to go through this suffering. We've got to empower our carers to be able to deal with those sort of difficult conversations too. So, no matter what discipline or how much experience or background you come from, you are going to be privy to some of those really intimate and difficult conversations, I think. So, I think it's empowering people with, we said it earlier, that permission to actually just stop, sit down and listen. I think that's probably, you as the clinician as medicine. So I think and empowering people to be the medicine in that situation, I think, is really important. And I think also in coming into that is that self-care too. So recognising that when we actually witness suffering, we suffer as well too. So being able to look after self in that sort of situation too, I think that's an important part of that mentoring process as well.
Yeah, and I think you make a hugely important point, which I'm passionate about, with the growth in the group of staff that look after particularly older people, personal care, assistants in nursing, whatever title they have. We have to remember the importance of the education for them in moments like that, because at times we tend to educate very well senior clinicians, but they have a hugely important role to play and have a right to have the support and the information they'll need when they can get probably the most difficult questions, because they're doing, in a sense, the most direct care and most intimate care, the showering, assisting with meals and pressure care, whatever it be, they're involved in that. So they need that empowerment. So it's great to hear you mention that.
Well, it's also recognising the role that they play in terms of things like physical assessment too. So, I was in a situation where one of our senior nurses was talking to the aged care facility manager about somebody's pain for about 20 minutes, and then it was decided we'd go and see the resident. I said, no, stop, wait, let's talk to the PCA. The PCA's actually been doing the bed mobilisation. The PCA's been doing the showering. They've actually witnessed the pain. They've witnessed what they're like during those vulnerable moments. So, we need to tap into that source of wisdom as well too. Yeah.
And I think your point there about tapping into all of the resources that we have. Yeah. And sometimes we just flat out forget that. Yeah. I've heard stories of people documenting in aged care where the reference point is one or two people in terms of what are the care needs, how they're presenting, what's the background, mobilisation, etc. And they don't often, they can miss the people that know the most.
Yes.
And you raise that beautifully. Now, we've got traditionally 3 questions that we close with. The first question is, what's one thing you've learnt in the past month that's really stuck with you personally?
In the last month, that's going to be a tough one. I think go back to the second question. I'll come back to that first one.
He's going to just set it aside for a moment. That's fine. What's your favourite personal learning tip?
I think for learning, it's the phone a friend. If I stop phoning friends, then
you stop learning.
I stop learning. Again, the lady who mentored me through palliative care, she'd been working at palliative care for over 12 years before I started. And she used to ring me up and say, what do you think about this, Steve? And I'm thinking, what are you asking me for? You know it much better than I do.
That's a great compliment.
Well, she was doing 2 things. One was she was mentoring by stealth.
Yep.
So she was actually getting me up to speed by asking my opinion. But the other thing is she taught me a very valuable lesson, which is always bounce things off colleagues.
Yep.
And nothing replaces that, that multidisciplinary engagement and collegial engagement in terms of complex clinical situations.
Yep.
They'll always see something that you don't.
Yep.
So, I think learning is about that collegial support and that engagement in a considered way, I think. Yeah.
And you may well have leapt to the answer to the third and final question before we pivot back to the first. And the third question was, what's the best piece of advice you've ever received about continuous learning? And maybe possibly part of that is the answer you've already given.
I think so, yes. But it's also, that's that engagement of that practical wisdom, the phronesis. Yeah. So it's actually being able to engage the application of knowledge in the moment. So, even in a workshop situation, you can still achieve that to a certain degree, I think. Can you actually teach practical wisdom? Well, I don't think you can, but you can learn it. But you can actually provide situations where people can start that reflective journey, I think, too. So like a really good example would be with the communication module that I do with palliative care is the very first image I show is the People's Choice Award for the Archibald Prize for 2013, which is a self-portrait by an artist by the name of Jenny Sages. And it's a portrait of her in a grief situation after she'd lost her husband 12 months previous. And the look on this woman's face is just incredible. And so I usually put that up and I say, what do you want to do? And, you get this huge plethora of different answers of, I want to give her a hug, or I want to give her a cup of tea, or, I want to leave her alone, or, I just want to sit beside her and, So it's that thing of it gives us an opportunity to actually then start reflecting as a group about, well, what is useful to say in that sort of situation? This woman's just lost her husband, of 40 plus years. This is a loss she's never going to get over, So for us to, look for the platitudes like, oh, you'll be all right, or, they're not, they're not particularly helpful. So that thing of, that reflective practice journey where you can actually start people thinking about, how they would deal with situations in the moment. I think you can achieve that in sort of a seminar workshop context, I think.
So we've got fabulous answers for questions 2 and fabulous answers for question 1. We're going to give you one final bite at the cherry and go back to the first one. I'll repeat it nice and slowly so you can think about where have I learned, what have I read, what have I done, what's one thing you've learnt in the past month that's genuinely stuck with you?
Well, I'm going to quote your facilitator again. I reckon that's a great quote, that Oscar Wilde quote, that thing of, education, it's not our task to fill the pail, it's to light the fire underneath. And so I think, when she said that today, I thought, that's it. Right. That's what we do. Yeah.
Perfect close off to our discussion today, Stephen. Once again, thanks very much for joining us on our Care to Learn podcast. It's been terrific to have you here and have a great conversation.
It's a pleasure. Thank you so much.